All right, thanks so much. All right, well, I've got right at the time, so we will get started with today's webinar. It is great to see you all, and I think more folks are joining. But as they do, we'll all just do this introductory part and we'll jump into it. So my name is Kim Mayo, and I am a program specialist with the DRCH SD program, which is providing this webinar today. This is the fourth webinar in a 5-part series that we have been doing. Today's webinar is Deepening Physician Relationships and Building a Referral Network. This webinar is being recorded and will be posted to our website along with the other ones that we have had in this series as well. So if you're just joining us, please take a moment, use that chat box and tell us who you are, where you're from, and what you do there. And we'd really appreciate that. There's several that have already done that. We do encourage you to use that chat box for any discussion that you may have, any questions that may come up at any point during the webinar. Just go ahead and type that in there and we'll get those questions or comments relayed back to our speakers. We do ask that if you, would love to hear from you. We'd love to hear from you and see your smiling face as well if you do have that camera option. We do ask that if you are not speaking, that you do mute your microphone. That really does help to cut down on any background noise that we have going on. But we do, if you have a question, feel free to unmute and speak. We'd love to hear from you. All right, and the next slide talks about our program, the DRCH SD program, and has our funding statement. And as I hope you know, we are funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. All right, in the next slide, I have the pleasure of introducing today's presenters. So we have Mike Milligan. He is the president of Legato Healthcare Marketing. And as a healthcare communication strategist, educator, and media trainer, Mike has directed strategic planning efforts for a variety of rural and other healthcare organizations, serving as counsel for CEOs and other executive team members. Before founding Legato, Mike previously served in the communication leadership role for Previa Health in Green Bay, Wisconsin, and Director of Public Relations and Strategic Communications with Aurora Healthcare in Milwaukee, Wisconsin. When he's not writing strategic communication plans, Mike likes to spend time with his family, fishing, kayaking, and hiking with his 2 golden retrievers. Sounds like a blast.
And soon to be hopefully snowmobiling. So.
Oh, well, I hope so for you. And we also have Amy Yaeger joining us as well. She's the Vice President of Strategic Marketing of Legato. Amy has been with us during this series. She has over 10 years of experience in healthcare marketing, and she is active in rural healthcare advocacy and was recognized for this work in 2015 as a rural health ambassador by the Rural Wisconsin Health Collaborative. She has also served as a clinic director for a family medicine and behavioral health clinic in Black River Falls, Wisconsin. And Amy she's a member of the Society for Healthcare Strategy and Market Development and the Medical Group Management Association. She works with clients throughout the country to improve their marketing, growth, and strategic plans. All right, before we turn things over to those wonderful speakers, we are going to do our polling questions. So those are on the screen there. Robbie will launch that polling. And we just want to give you guys an opportunity to assess kind of your knowledge before we jump in. So that there's 2 questions to start off with. So that first question is, we want to know how you are and how your confidence level and understanding of how to increase the volumes of my primary care team. And then that second question is your understanding of how to seek new revenue opportunities and expand your organization's service area by expanding outpatient services. Oh, there's a third question. And then we want to know your understanding of how to establish and build relationships with referral sources, including providers, discharge planners, case managers, and others. So we want you just to take a moment, complete those questions. When Robbie sees that most of those responses are collected, she can close that polling. And I did not say earlier, but happy Veterans Day to everybody out there, and especially if anybody has served in our country, we really appreciate that. And thanks for joining us on this very special day. All right, Robbie, how are we doing on the polling?
We have 17 out of 30.
Okay.
I'd say give it another 30 seconds and move on.
That sounds great. Thank you so much. All right. Wonderful. Well, we will turn it over to you guys, Mike and Amy.
Sounds good. Sorry, I'm just having a little technical difficulty here. Hang on. All right, hang on. Just lost my. Here we go. Okay, very good. Not sure why I see a little line on my screen here, but do you guys see that too? That little. I'm not sure where that came from.
I actually just touched my screen to see if it was on my screen. But
You did the same.
That's bizarre. I'm not sure. But anyway, I'm sure you can figure it out. So, good morning or good afternoon, everyone, whatever it may be in your part of the country. And again, thanks for joining us today. This is a very important topic, obviously, and one that I think, as I kind of look at the different backgrounds of the people on here, with we have an eclectic group. We have people in the C-suite, we have project managers, we have community champions. And that's wonderful. And one of the reasons I mention that is because as I've done these webinars in the past, we really try to keep these, as casual but as interactive as possible as well. So as Kim mentioned, if there are questions, certainly use the chat box, but we'll kind of monitor that as we go through as well, because maybe there's some things we can pause and talk about during. And I would just encourage you too to, if you want to speak up, to unmute yourself and go ahead and ask a question. You're not interrupting us. This is about learning. And, with that as well, Amy and I are certainly going to share our perspectives, but there's a lot of experience on this call. So if you have experiences that you want to share with others, we can all learn from each other. So I just, encourage you to do that as well. So, why focus on strengthening provider relationships? So it's very interesting, as a, a matter of, business, we're always looking at, okay, how can we, build our business, sometimes increase our communications, expand our service lines, those types of things. And there's lots of ways to do that, but I think one of the overlooked ways sometimes, and we don't oftentimes mean to, but kind of maybe sometimes even take those provider relationships for granted. Either what's that current relationship that we have, how can we strengthen it? Really looking at either current providers or prospective providers, and kind of really looking at them in a way as a customer. Just like or as a or a patient. What are their needs? How can we meet those needs and those types of things? So certainly, why that's important. I think it's fairly intuitive for us here, but certainly just as we look at building our business and referrals and volumes and expansion of service lines. So even as we're looking at maybe within our facility that we're going to be able to bring in a specialty provider, even as a visitor. How do we nurture those relationships? And certainly that translates into revenue for our organization, certainly. But it's also just overall about building the image of your organization, and really, and particularly in rural health, of really position yourself in the future and currently as one in which people can receive, complete health care. So also results in just more efficient utilization of our resources. And again, by strengthening those relationships, we allow ourselves hopefully to retain our providers, as well as creating an environment in which we're recruiting new providers. So, just kind of I'm not sure what this line is through, so I apologize, but I don't know how to take it off at this point, so it'll keep you interested to look at it. So I just went through this. I don't know. It must be user error. I must have done something that I don't realize. But anyway, just to give you a quick background again, we know this from the work that we all do, but certainly we look at and say, patients have a choice of where they're going to go, or where they're going to be referred to, or where they're going to go for their ancillary services, those types of things. And they do, no question about it. But the reality is that providers influence decisions as well. And those relationships that we have with providers translate into public opinion and public perception. So you can kind of see here more than 70% of provider referrals go to their top hospital partner. So those the purpose in nurturing those relationships, and in particular, if we have where we're competing, in rural communities, oftentimes, obviously, our competition, if you will, might be a larger, municipality, a larger city. Maybe it's an hour away, maybe it's 2 hours away. And we need to look at how are our relationships stronger and tighter than they might be in some of those other areas. So how do we strengthen those relationships and build those referrals? Well, our philosophy here is that you are starting with strategy first, and we'll kind of explain what that means here in a little bit. But so just kind of more of a hypothetical question here. This won't be a poll, but I just kind of read it out here, and you can. But what is the most important preliminary step in the strategic planning process, or your business planning process? And the hint is many rural hospitals neglect this step, which often results in maybe overspending or not spending things in the right area. If you're doing communication campaigns, how are those performing? Just, overall opportunity that you might be missing if you're kind of just shooting from the hip in terms of, your communication plans and your recruitment plans. So what we're saying here is that just like anything, whether or not you're doing your strategic planning or you're looking at how you're going to increase your communication, and I would say in particular, as we're working with providers who are obviously very science-minded and science-based, is to have a plan and to have, data-driven sort of decisions that we make. So, so with that, as we look at, for instance, creating a communications plan for your organization and looking at where potentially you're going to draw patients from or reduce out migration, those types of things, is using data to make those decisions. Now, there's various data sources that are available. I won't go into that for today necessarily, but if you ever have questions on that, we'd be happy to share some resources for you in terms of how to do that. Sometimes there is state data. We sometimes might work with an organization that, for instance, has access to healthcare advisory information. Whatever, you might have this already available in your organization and you really don't realize it. You know what I mean? So, but in general, what kind of data you're looking for is, being able to understand, okay, where is the market going to grow? Or where does it have the potential to grow? What are some of the areas in which we can expand as an organization? What are some undermet needs? I mean, oftentimes too, you do a lot of this work as part of your community health needs assessment too. And I think it's sometimes just going in and looking at what you've identified there. One of my just observations is that I feel sometimes that as rural healthcare organizations, we really don't use those community health needs assessments as much to actually, there's a lot, as those of you that are involved, there's a lot of work put into that, and sometimes you're using research, focus groups, those types of things, and just always going back and looking at that as a basis for what you're going to do. And I would just also just say that always being aware of, other organizations and what they're doing right and what they're doing wrong. and just, having an ongoing understanding of that. And that can mean from a communications perspective, it can mean from different programs that they're offering or considering. Just to remind you that, even though we always advise that if you were, you need to focus on your organization, but we also don't want to work in a tunnel or a vacuum. We want to be aware of what other people are doing. Maybe we can learn from them. Maybe there are opportunities that we can capitalize on. So just a reminder to you on that. I don't know about this mark. I can't erase it now, so I really apologize. But
This mic is bothering you way more than it's bothering anybody else.
oh, okay, good. At least it's the same color. If it was like red or something,
Yeah, we're good.
I'm probably showing a little bit of my type A or my ADD or whatever, however you want to diagnose me. Oh, what happened?
Oh, it went away.
What is going on?
It was an
What?
annotation. I fixed it. We're good.
What was it?
It was an annotation.
I don't know what that means.
It's all good.
Okay, who fixed it?
I did. My name is Robbie.
Well, thanks, Robbie. I don't know what you did, but you have to tell me. Thanks. Appreciate it. But anyway, so as we're looking at, and those of you that have maybe been involved in some of the marketing planning presentations we've done before and such, just kind of a reminder that there's a lot of things in terms of looking at, priorities, how to set priorities in terms of, uh, what to focus on in your organization, what not to focus on. And these things all relate to your physician engagement as well, because these are all ways in which you need to be involving your providers in what we're doing from a communication standpoint, and for them to understand that there is a process that you go through. So when you're getting, for instance, questions about why are we communicating this or why are we not doing that, or that they're involved in some way with this. But this is just a quick example of some of the things that we think about in terms of how are we deciding whether or not something warrants more attention than others. And certainly, one of the things that we have primary care on here, but one of the things that really could be on here is, does it help in terms of, if one of your priorities in your organization is retention and recruitment of providers, then as you're looking at, okay, what are some of the things that we're going to communicate, or some of the things that we're going to market, if that's a top priority for you, then that's going to be the things that you're going to focus on more than maybe other things. But anyway, just as you kind of look at this list, as you're trying to decide, okay, what am I focusing on as an organization? Some of these things are just, just to kind of be mindful of that, because we get a lot of requests in our organization for things that maybe are important to the people asking, but they're maybe not as significant to what maybe is in our strategic plan of our organization. So things like, does it bring in profitability? What's the downstream revenue? We kind of talked about the competition, differentiation. How does it build our patient experience? Ultimately, how does it help communicate that patient experience? How does it enhance our image? So just a quick reminder of some of the things to be mindful of. So, and then as we do that again, we're looking at how do we focus on the right priorities, and generally we have a kind of a standard that we look at, but what's more important is how do you do this, and that the concept behind this is that as you're looking at the various things that you're promoting, the service lines that you're promoting and things like that, that we only have a certain budget that we need to work with. And so the idea is that you do a finite amount of things and you do them very well. And so we kind of suggest you break things into tiers, and you might have only a few things that are in tier one, but it's going to occupy 60% of your resources. And you might have, 10 here and 10 here, and you kind of just see how the math works with this. But the idea then is that, you remain focused. And so how this really relates to, the physician dynamics that we're going to talk about even in more detail here in a second, is that just like anything, if physician relationships and physician referrals and retention and recruitment is a priority in your organization, you have to ask yourself, okay, at what level and how and if we're if we're going to place additional emphasis on that, what specifically are we going to do, and what kind of resources does that take to do that? And the reason I bring that up is because, again, it is a fundamental part of the development and the growth of your organization to be thinking internally in the relationships that we have and those types of things. And so it just kind of a reminder that I think sometimes physician referrals and relationships and all of that are a little overlooked. They're almost kind of what I've seen is they're almost assumed a little bit. And so if you really have sort of document those things, and if you're doing a communications plan of some sort, that you're really, having that be part of your effort and saying specifically, what are we going to do? That oftentimes really focusing on those types of things can be more important, and we do advertising, so I'm not, discrediting advertising, but it's more important than advertising. You kind of have to have your house in order first. You got to have those referral relationships, and you got to have, that network going, and having people feel part of the larger team, and being satisfied with the quality of the organization, and that their physicians are wanting to refer to you, and all those sort of things have to be optimized first before you kind of go the next step in your growth of your organization. So part of that, again, I just kind of hit this very, very broadly at this point. I want to make sure I have time for Amy to go through what she has here, but just as a reminder that as we're forming our communication plans, that we're always thinking about setting proper objectives. And so I know you know this, but the most important thing when we form objectives is to have metrics behind them. So in the context of physician engagement and things like that, to be thinking about, do we have a physician engagement survey? Are we measuring that from, specific questions that are being asked, and how are we doing at one point to the other, and then to have some goals around that in terms of, we want to increase, physician satisfaction from here to there, or whatever it might be. Maybe we have part of our organization that we have someone who is specifically responsible for doing rounds on physicians, or I know we're limited in our resources sometimes, but do we have a physician liaison that whose responsibility is to specifically work with primary care doctors and referring physicians and identifying opportunities, and then really again trying to set some specific goals around that. So with that sort of as a basis, and kind of thinking again, our goal here, as we look at physician relationships and increasing primary care volumes, is to first think strategically, and making sure we have a sound plan, we have measurable goals, and we look at how does that fit into our communication plan. Now I'm going to hand it over to Amy, who's going to talk a little bit more specifically about maybe some specific techniques and just kind of things to be mindful of that. And it's really helpful, by the way. I think you heard that her background, in addition to marketing, is serving as a clinic director. So she's going to be speaking firsthand about some of her experiences. So Amy, I'll turn it over to you.
Thank you. So just to give a little bit of background on my clinic director position, I was a marketing director for 9 years at a small critical access hospital in Wisconsin, and we were opening a patient-centered medical home clinic. Our EHR was Cerner. So you're going to hear about the EHR today. So just my frame of reference is Cerner. Obviously, we all use different EHRs, but there's a lot of things that I learned being a clinic director that I wish I had known as a marketing director. And that's really where my side is going to come from today. And it's really about the physician relationship bus and who's all on that bus. Are they in the right seat? Do you have a driver of the bus? Those were things that we found out we were lacking. So It was a huge learning opportunity for me. So I'm going to give you some super helpful nuggets today on this. So we'll get started right away. One of the things that I learned through the MGMA, the Medical Group Management Association, is that your downstream revenue per primary care provider on average is about $1 million per year. We knew we were starting to see some of our downstream revenue services, our ancillary services, start to take a little bit of a slide. We knew that we had an access issue for primary care and especially behavioral health care. So we knew that we needed to make some changes. And we realized that we had an onboarding issue for our new physicians as they came on, because they didn't know what we all had to offer locally. And if they're coming from outside your community, like so many of our providers do, they go with what they're comfortable with. So it's our job to educate them on that. So we started a social media campaign to let the whole community know that these offerings were going to be available, and shared those in a monthly update that went to our providers. I had a chief medical officer who kind of was my right hand, and he had an assistant who would help us communicate and let them know what was out in the community, because we needed them to know what was out there. So when patients ask them, well, I saw this, and they're like, oh yeah, okay, I saw that too. And they know that you've got a referring provider for this service or that service. Because some of our new providers had no idea. Oh, they have an orthopedic surgeon here. Oh, wow. And they visit in the primary care clinic. Oh, okay. So that was super helpful. We developed print communications that were sent to homes, very targeted per age group. You can buy those lists to make them as targeted as possible. We also had a CRM that we used to target our current patients, to make that even handier and more deliberate in our target. And then obviously text messaging and email reminders were a big part that came through our EHR. You can certainly hire other third-party vendors to do that work for you, but more than likely it's already in your EHR, or something that a module or something, whatever your EHR company calls it, that you can add on. So online reviews, as we talked about in our online reputation management one a couple weeks ago, remember that 89% of consumers are looking at those reviews. And then 56% say that those responses have changed where they go. So keep that in mind as you're doing those reviews. And I'll give you a couple tactics on that. And one of them is just slipping a little piece of paper to each of your primary care patients as they walk out the door with a QR code that they can enter. They can do it while they're waiting after they get done with their primary care appointment. So just a little tidbit there. So next slide, please.
And Amy, there's a question. Can you recommend a good CRM for clinics?
Oof, that's a
I know,
really good one.
I know. Do you have an hour? Do you have an hour?
Yeah, that could be a whole separate webinar. Keep in mind, you get what you pay for. They can be very, very expensive. But if you want them to be robust and tie with your EHR, you're going to need your IT department. I would use your purchasing manager to help you evaluate that process as well with your EHR company, because many of them have third-party vendors that they work with directly. For Cerner, it was Salesforce. And that seems to be getting better and better every year because they know that it's needed to help maintain those relationships. But there's also things within the EHR that we're going to talk about in a couple of slides that already exist to help maintain your relationships with your current patients and keep your providers happy because you're maintaining those relationships for them.
What we can do real quick is we'll send afterwards to Kim maybe a top 10 list or whatever ones that you might evaluate, and then if she wants to, she can share that with you just as a something that you can evaluate. So okay.
So one of the things that we did with our patient-centered medical home is we looked at our EHR data for emergency room and urgent care patients and looked at when they were coming in, when it really started to amp up and when it started to amp back down in the evening. And we came up with the hours of 7 a.m. to 7 p.m. So we were actually open, and they still are, 7 a.m. to 7 p.m. Monday through Friday, and then 8 to noon on Saturdays. The patient-centered medical home, that process we used NCQA, the National Committee for Quality Assurance. They're the gold standard, right, for that process. And you have to have patient-centered care hours to actually get accreditation through them. So that my IT, they were pivotal on my bus and being in the right seat. to be able to come up with all the data and the metrics to help us drive these decisions for our providers. And coming up with a provider schedule that, okay, it's 7 a.m. to 7 p.m. That might seem arduous to a new provider as you're trying to recruit them. We developed a schedule that was very family friendly, where they had a 3-week rotation, and one of those weeks actually offered a 5-day break, because we know 7 a.m. to 7 p.m. can be a lot for a provider. And then we had 10-hour shifts and would rotate that way. So that was one way to keep the providers happy with that patient-centered hours. And then obviously telemedicine has completely ramped up since COVID. So there probably isn't a whole lot I need to talk about there, just because it's kind of become a staple in providing care. But that was also something that we did not know. We were using Zoom. And then our EHR company was like, do you know we offer this through the patient portal? And we just went, what? And we had it the whole time and didn't know it. And again, it was because we didn't have the right people on the bus. So having your EHR super users or content experts be at that table is so important when you're making these decisions. So we were able to do that all through the patient portal. They could even schedule, or they had a schedule appointment. We weren't ready for that as a new clinic. We let them request appointments so they could see the open slots that were available based on the schedule as patients were being booked, and could request an appointment time. Chronic care management, that is something that I would definitely recommend that for telemedicine, and your wellness visits. You don't have to physically touch the person to have a wellness visit and get your reimbursement. So, and providers like that option because it makes the patient really happy. Offering your online scheduling, I kind of already talked about this, but you can also get, depending upon how robust your EHR is, having them pre-register, having them fill out forms. That was built right into our patient portal, where they would have all their COVID screening was done before they got to us. That would automatically be, it was an automated process through the EHR. And then the providers could actually look at it before the patient came in, which was awesome. Patient education would be delivered through that as well, before and after the appointment, based on what happened at the appointment. Our surveys were conducted, our survey vendor was PRC, and that gave us the option of a phone survey or an in-person survey. We obviously accept Medicare as payment, but and that was super helpful for us to be able to have a phone option rather than having them mail in a survey, because we got very poor results with that. So that was one thing that really changed for us. And then offering your messaging, text message reminders. That was something that was available in the EHR as well that we didn't know about right away. Our rehab department was thrilled because they were kind of our first clinic. So both of us were able to use those appointment reminders rather than having to physically call the patient every day for the next day's appointments. And if they didn't want text reminders, they could opt into how they wanted to be reminded: email reminders, phone reminders. And those are automated phone calls as well through the EHR. So get your EHR expert on board. Next slide, please. All right. So as far as preventative care and chronic management, our MAs actually scheduled the patient's next appointment right in the room before they left. We did not have a separate scheduling station after they left. They didn't go back to registration to schedule. That was something that the MAs were able to do before the patient even left. This keeps your patient care consistent. And at first the MAs are like, oh my gosh, their appointment isn't for the next year. I'm supposed to already schedule this out. Yep. You will, and you get it on their schedule. They automatically get a reminder. It gets in their patient portal. They can pull it into their calendar on their phone. More and more of our patients were using that in their phone. They get it out to make sure that they're available. It was really, really handy. And then reaching out to those patients that haven't received care. Maybe they weren't able to set up their appointment. They were in a hurry, needed to get back to work. That's okay too. And we had a nurse within our facility that our EHR would actually provide those reminders through something called the health maintenance tab. Almost every EHR has this capability where it keeps track of your patients who might need a colonoscopy screening and reminds them, within 5 years that, hey, you're due for your next colonoscopy screening, etc. So, and that can be just for general wellness visits if they have diabetes or high blood pressure. Those are automatically set up through EHR. So something to work with your your IT team on. The other important seat on the bus is your HIM team, because they can help you identify certain patients, because they're registering all of your patients on the ER side, on the clinic side. They know all the fields that are required to register a patient. So when it comes to building reports, and you get that information back and you're like, well, this is incomplete, or we've got a lot of unknown fields, it's probably because something's being neglected on the registration side. So if they don't have a PCP and we've registered them in the EHR as no PCP selected or unknown, we can target all of those patients to align them with a PCP. That was the specific report that we used on our side to get them aligned. And then we also had a process in our EHR of it was actually a handwritten report. If we had patients that needed follow-up, that we could have them come through our clinic rather than coming back to the EHR, because, or through the ER, they could come back to the clinic and start that relationship with our PCP. So kind of manual, but it was, one or two patients from the night before that might have needed that relationship to be built. Next slide, please.
Amy, real quick, I know this is kind of a broader question, but maybe you can just answer it at a higher level. But the question was, do you feel Cerner was able to provide all you needed for the patient center medical home?
They're actually certified as a PCMH vendor through the NCQA. They've gone through the entire process. So that was another really important person on my bus was the Cerner folks. I actually had my own Cerner person that helped walk me through the whole PCMH process and the application and making sure that I got all of those boxes checked. So I would say they were probably top notch in the whole PCMH journey.
Great. And I just make a note, if you're interested in more information or talking more through it or whatever, if you reach out to Kim, and she can always look for opportunities if you want to pick Amy's brain on that a little bit more, something like that too. So okay, all right.
All right, so we kind of already talked about working with ED and your discharge team to have them refer patients without a PCP. So the same thing can happen if you have a patient that ends up on the med-surg floor for observation or an inpatient stay and they still don't have a PCP. You can work with those planners on that floor or in that department. And like I said, that manual report, it was very manual. I even worked with my social workers up on the second floor to get those names down to me so that we could have follow-up. I was that person. I was the one driving that bus. And then I would personally talk to a PCP who might be at, if their practice was already closed, or I had another provider who they kind of aligned, designated that they want a male or a female. I would have a personal conversation with the provider to say, hey, this is what we've got. Are you willing to take this patient? I'll be happy to set up an intake appointment with them. And the providers, we communicated every single day. We had a standing huddle every day at noon to talk about patients on the primary care side and the behavioral health side. So that was also a really nice trick, because noon we were all there. Everybody had to eat. And that was the time where I knew I had all of my staff. And the MAs were always included on those conversations because they have a huge impact on who your patients see. So let's see. And then identifying the PCPs who are accepting new patients. I just talked about that. And you can also put that information on your website. We chose not to do that. We just showed everybody who provided service on our website. All right. And then the next one, building out your website and patient portal, the patient portal is pivotal. And if you're not the driver of your patient portal, I was the patient portal person as the marketing director when we had our conversion to Cerner. So I would highly recommend that if you're not that person, you become best friends with that person, because it's branded in your brand. It is the messaging that's being put out is pivotal, how it's presented. We discovered that it was presenting the patient's weight in kilograms, and that it was presenting height in centimeters, which is great for medical staff, but it means Zippo to your patients. It was presenting blood pressure in 2 separate numbers. And were they good? Were they bad? So working with Cerner up front to make sure that the patient portal was patient-centered was also important because they have default settings. So it's just a matter of working with Cerner to get that where we needed it to be. And then again, that health maintenance tab, this is a really important one within Cerner. I don't know what it's called in other EHRs, but it's automatically set up to do those reminders. For chronic care management, it walks the nurse through all the steps that are included with chronic care management, what screenings are needed, what blood tests are needed, all of that stuff. So I would say that getting a nurse also on your bus and an MA to help lead this process is super important for your providers. You can't put all of this on your providers, and making it as easy as possible for them is so, so important. And then the last thing is leveraging your storytelling and going from the marketing department to the clinic department. It was super easy to go back to the marketing department and say, we've got some really awesome stories to tell already within the first month of being open. Talking about our providers, getting their provider stories on why they went into primary care. There are lots of facilities that still do not have provider videos. I really think that's important. It helps set the tone with the patient and aligning with the right provider. Some of them are going to hate it, but they know that they need to do it. Print is so important in those direct mail lists that I referred to before. Hitting up specific patients without a PCP, so important. You don't have to, you'll kind of probably tick off the people who already have a PCP. So don't do a general one to your whole patient list. You've got the data. It's just a matter of getting it. All right. I think that's it.
And one thing real quick too that I would just mention that's not on here that is being mindful of, there are different conversion programs that you can kind of think through. In other words, when people present to ER or walk-in care, in terms of determining whether or not they have an established primary care physician, and there's a whole slew of techniques that you can use there in terms of, it really starts with making sure that the staff are properly trained to be able to identify that and recommend providers and things like that. But then even to Amy's point, if you have those physician videos that are available, then you can refer them to the website and say, learn more about these providers, that type of thing. So
the next one talks about how I actually built the relationships. So first and foremost, we knew we did not have anyone driving the bus for physician relationships. So my best friend became credentialing. She was pivotal in onboarding and knew what the providers knew, what they didn't know. She was at the medical staff meetings each month to know what was being covered for them. She was pivotal. We had something called the Stoplight Report. That was that monthly report that I was talking about, where we all worked together to come up with the right content, really short bullets, 3 columns of red, yellow, and green. Red, this is on hold, we can't do it. This is why we can't do it. Yellow, these are the things that we are waiting on this, or we're waiting on that. And then green light, we're going ahead. This will be when it times out. We have a new referral provider for orthopedics. We have a new piece of equipment, training will be this date, those sorts of things. That really helped us to make sure that we all were on the same page. The whole director team saw that communication with the providers and onboarding providers. We developed a whole new onboarding process with all of the stakeholders that needed to be on that bus to make sure that the providers knew what they needed to know. At those daily huddles, I would even bring in, like, for example, we were seeing a decrease in sleep labs. Well, we realized our brand new providers didn't know that we had a full service sleep lab accredited upstairs. So I actually had the sleep tech and the sleep manager come down and talk about it really quickly, gave them the materials that are shared with patients. And guess what happens, right? They know what they know. We also made the other thing that needed to happen with onboarding providers was how to do a referral within our facility, because every department was doing it differently. So that was another process that we realized was broken. And guess who solved that? The EHR, because they had a referral management tool that we didn't know about. It was brand new. So that was part of the issue. It had just been a new module that was produced. So we were kind of a guinea pig, actually. We went beta with it. And that to get away from paper, because all of our referrals were being done by paper. Providers, that they don't really like that. they want it to be as seamless as possible. And if your MAs are doing that referral process for them, they want it as quick and smooth as possible. And automatically the message center is pivotal in Cerner for those of you who use that. And everything goes through the message center, and it is fantastic. And that's for all in-house referrals. And then they also have an external referral process as a part of that. It's a lot easier if it's another Cerner client, just heads up on that. Not so nice if it's not. And then a physician satisfaction survey. We learned a lot about that. We actually were doing them annually, and the physicians hated it. They had better things to do with their time. So we actually went to biannual, and that helped our survey scores because they didn't want to be bothered with a survey, actually. And it honestly, the feedback didn't change that much in those 2 years to make that data change, but we at least still got their opinion. And it was a separate survey from the employee survey, which I think is really important because it should be a shorter survey. It should be very directed towards providers only. Next slide. One of the things that we did was working with potential tertiary centers and regional partners. And you're like, well, isn't that your competition? But they might be providing services that we would never be able to provide. Our CEO, that was her bag, and it was her jam. She loved to network with other facilities. And I think that's really important for bringing that back to the organization and the CMO. And the CMO would also network with tertiary centers. And he actually took a social worker out with him because he was also a hospitalist for us. And they helped increase knowledge for our tertiary centers on those as well. And then that, I think the main thing is that you're also letting them know that you're as competitive as they are. You have as much to offer as they do, and try to help them remember that there's a patient on the other end of this to keep them local. So, and again, referral management is a tool that you probably have within your EHR that can help with that as well. And then building relationships with your referral sources. Another driver or a rider on the bus is your social workers or discharge planners or case managers, whatever you call them. And maybe you have all three roles. They helped in rounding on our local nursing homes and our public health staff to know what was out there, people that we needed to address that weren't coming into the system at all, especially our public health staff. And that was really, really helpful. And it was so great that our social workers had the capacity to be able to build that into their schedule. And it actually helped them to provide better service on the med surg floor. And we ended up created a community health improvement network. And that was one of the tactics that we used with our community health needs assessment. And that network included anyone that came into contact with patients. We even included a local police officer as a liaison, especially for behavioral health. They might be pivotal in getting that person to the right care. And then again, taking your show on the road and getting that information out to other community organizations, other healthcare providers within the community. Those are all really, really important. And I needed my social workers to be that person for me because they were so close to the patient care and knowing what was out in the community, what the needs were for the patients and which groups we should really be focusing on that we were struggling with as patients or not as patients. So, all right. And I think, yeah, you get to take this home, Mike.
We still have you here, I believe.
We do?
We do.
Oh, we do.
I'm happy.
Oh,
to
yes.
take it.
Okay. Yes. I forgot about that. Yes. So obviously you all probably have these same challenges, right? So you're seeing, you're in a small community, there's so many people, but if you work with your marketing department on some market studies, we actually worked with a consultant because we were having a really hard time getting clinic data because they're not required to report like hospitals are, right? So we actually worked with them to help us really know where people were going for primary care. And so that our providers could understand people really, truly are leaving town for this care. That was really important for helping them to understand. Obviously, we know that there are provider shortages. We really worked hard to get APNPs and PAs into our office to be able to help fill that. And a lot of our patients had what I often heard from the MDs or DOs was, well, no one's going to want that for primary care. And that's not true. So I think we all know that the APNP is definitely increasing their role within the clinic. And we worked with a recruiter to help us to get those spots filled, because as you know, that's very difficult. Working directly with your competition for referrals. It's something that isn't really done. And again, it's having the capacity, having the owner to be able to do something within your organization. That gatekeeper is so important. And then all of the challenges that come with adding a new service line. We also worked with a consultant on that to help us know which new service lines we actually needed to add. Our CFO was pivotal in getting that relationship started with a consultant who could help us with that, and developing a pro forma for all of those service lines that truly gave us the right picture, because we really didn't have a process for that either. And he was pivotal in helping us to get that pro forma right, to know that we had the right new service lines coming in, and your AHR can also provide some of that reporting for you too.
Okay, thank you, Amy.
Yes.
Good stuff. I'll just finish up here in just a few minutes, because I want to make sure we have time for any additional questions that people might have. Just as a quick, Amy mentioned, the idea of we kind of call co-opetition, but cooperating, but competing, maybe with other facilities, whether other tertiary facilities or not. And just as a quick example, Barrett Hospital's a customer of ours, are in Montana. They're a critical access hospital. And there were two particular areas that, among others, that they wanted to grow, and it's pain management and vein care, and surgery as well, obviously. But the point that I want to make here is that this is how this really relates to the physician relations that we're talking about, because their situation was that, and it's similar to a lot of organizations where they knew that there was potential to grow in these areas, but the projected volume didn't quite justify hiring maybe the full-time providers that they needed. And so they looked and said, okay, how else, is kind of Amy said before, how else can we think outside the box? How else can we, figure out a solution for this? And so they ended up actually, forming new relationships with people that regional partners that might actually be considered, competition in some ways. But, so to kind of make a long story short, through that cooperation and actually sharing of providers and communication, it was a win-win situation for them. So just an example, it's a tertiary facility, provided new revenue streams for them. Just kind of moving forward, they had, some great results with it that I can share with you. And then they, combine that with a number of different, marketing techniques as well. But you can kind of just see here some volumes that they really would not have been able to achieve if they didn't think about physician relationships in a different way. If they kind of just looked at things from a traditional sense, they probably wouldn't have been able to afford to do it. And then, overall, because of that, they actually were recognized as a top 20 critical access hospital and have a 10-year record in revenue growth. So anyway, just wanted to share that as an example. And Kim, before we take any questions, I think you had a final poll question here.
Yeah.
Or maybe it's this. Okay, go ahead.
Yeah, we'll go ahead and do that. We'll go ahead, and so that'll give you guys an opportunity to think of any questions that pop up, and we'd love for you to unmute your mic or just go ahead and start typing those in that chat box there. But yeah, there's 4 questions that would wrap up our polling for today. And so we just really want to know if your knowledge now on the understanding of how to increase volumes of your primary care team. And then also we want to know about your understanding of how to seek new revenue opportunities and expand your organization's service area by expanding outpatient services. Question 3 there is about your understanding of how to establish and build relationships with referral sources, including providers, discharge planners, case managers, and others. And then lastly, there is, we would like to know how you will apply the knowledge gained from this educational training to improve your organization's community outreach and education efforts. So we'll leave that up for just a few moments and let you guys have an opportunity to complete those questions. In the meantime, feel free to ask away, ask our experts here. Okay, and Amy put in the chat, that's very helpful. Amy, if you guys did not see that, Amy added a note for CRMs. Your EHR company will have a list of compatible CRMs. They have worked out the bugs and made integration smoother. So that's very helpful as well.
I do have something, I'll always talk, but I have been in PR 25 years at a hospital or a healthcare setting. And Amy, that is the most valuable information I've heard maybe in my career. I know I need to be doing those types of things, but I didn't know how to pinpoint it. And our bus, I love who drives the bus, what seat you're on the bus. Our bus is that bus on the movie Speed. That's just like, we got one person in this one, but like, seriously, I cannot tell you how much I just learned. It may be the most I've learned in 20 years in my whole career. Seriously.
Oh, I'm so happy to hear that, Patty.
It's common sense things that we can do, talking about us being more involved with the patient portal, from scheduling it. I mean, you hit everything that I needed. So, I mean,
Wonderful.
Mike was great too.
That's okay.
But what
It's
Amy
okay.
did,
Give her all the
made
credit.
my life like get recharged of what we need to be doing. And
Oh, that's so wonderful to hear.
yeah,
I'm
and
so
some
glad to
people
hear
may
it.
be a little newer to the PR or marketing world, but I'm an oldie, and I can't tell you, Amy. I mean, like we want more sessions with Amy. This is awesome. Awesome.
Okay.
Thank you so much.
Well,
Yeah,
I
I
mean,
don't know if we even had a bus with tires when I first took this on. So
but the fact that you've been there and you've done that and you've worked those processes, and you're not just a marketing firm saying, here's an ad campaign.
Right.
I mean, that might or might not hit your needs.
yeah, it's so important to optimize the tools that are already there. And if you don't know about those tools, how do you even do it? And so getting all the right stakeholders, it will help. And let me know if you have any other questions as you go on that journey, Patty.
Oh, I got your information, sister. Thank you very much, both of you.
You're very welcome. You done made my day. Thank you.
And you
Made my
have
week, maybe. I think.
that's a great accolade. You also have a thumbs up as well from Kelly, who says that she agrees with Patty. You always seem to say whatever I'm thinking.
Very nice.
Thanks.
Any other questions, comments out there? It was just a wealth of knowledge, and the series has gone by so quickly.
I know.
I mean, next week will be our fifth and final for the series. So all of these sessions have been recorded and will be on our website, and we'll be sending out links to those as they're all uploaded and at the conclusion of this series. So you'll have access to those and be able to share those within others within your organization as well. All right, any final questions or thoughts? We don't want to cut anybody off, but have two whole minutes. So yeah, well, Mike and Amy, we just thank you so much for sharing just great information with us today. And we thank our audience for, of course, our participants for joining us today as well, on a holiday for some. But we thank you for just this great, again, just wealth of knowledge, just very practical use for information that you guys are able to provide for us. And we do hope that you all will join us for next week, as we said, the final webinar in the series, and we'll be talking about evaluating the role of community communications in your organization. Did I get that right? I think that's on the next slide.
I think it's on the next slide.
Yeah.
Oh, sorry.
Mike's done.
I'm sorry. Sorry.
Yeah.
Was that my cue? I'm sorry. I missed my cue. Sorry.
Yeah, there you go. And Mike, you'll be presenting that one for us?
I will. Okay. Yes.
Perfect. So that'll be another great webinar to look forward to next Thursday. Same time, same place. So we look forward to seeing you all then.
Great. Thank you, everyone, so much.
Thanks
Appreciate
for
it.
joining
Good to
us
see you.
today. Great to see everyone. Bye-bye.